Before we get started with the session today on Rapid Response Program, I would like to thank all of you for taking the time to join us. I'd also like to recognize the funders of Cochrane Canada, without whom these webinars, our training, systematic reviews, and capacity building could not happen. Thank you to CIHR and their institutions for their support, and also we would like to acknowledge the Ontario Ministry of Health and Long-Term Care. In addition, I would also like to thank PAHO, the Pan American Health Organization, for kindly providing the software for our webinars. And a special thank you to Dr. Luis Gabriel Cuervo, who converts our webinars into YouTube videos. It gives me great pleasure to introduce Dr. Michael Wilson as our speaker today. Mike is the Assistant Director of the McMaster Health Forum, as well as an Assistant Professor in the Department of Clinical Epidemiology and Biostatistics, and a member of the Center for Health Economics and Policy Analysis at McMaster University. His research focuses on supporting the use of research evidence by health system decision makers, including policymakers and community-based organizations. Mike is the lead for the McMaster Health Forum's Rapid Response Program and previously developed and led the Rapid Response Program offered by the Ontario HIV Treatment Network. Thank you for being here with us today, Mike. I will now hand the webinar over to you.
Great, thank you. And it's great to be here today to share some thoughts with the Rapid Response Program with everyone. And so thanks to everyone for joining the session to hear about it. So I'm just going to get to the slide. So as I said, I'm just going to talk about our relatively new Rapid Response Program that we've developed at the McMaster Health Forum that's specifically targeted towards health system decision makers in Canada. And so for the overview of the webinar, I want to start off with a little bit of background and rationale, first talking about evidence-informed decision-making and what that means, as well as generally options to support the use of research evidence and where rapid response programs like the one I'm talking about fit within those options for policymakers, as well as some specific rationale related to why rapid response programs are helpful and needed. And then more practically about the program, I'll then run through some key features of the rapid response program, as well as our approach to evaluation and some next steps. Sorry, should I stop? I'm seeing some messages pop up related to the audio. So are people having issues with the audio?
Yes, Mike, they are. Some people are finding it echoey. I don't know if you have a headset on or not, and whether you're moving around, perhaps. They are going to be, maybe turning down your volume or turning down their volume, perhaps too. We could try that.
Okay. So I do have a headset on, and I'm not moving around. So hopefully it gets better as we go on.
Okay. Sometimes it's just the connection too.
Okay.
So we can hope it improves.
Okay, so I'll move ahead for now. So to start off, before I get into some of the talk, I just want to start with a poll and ask some of you to respond, if you can, about what is your primary role, just to get a sense of the group that we have together today. So could you answer A, B, C, or D based on whether you're a researcher, a policymaker, a health provider, a student, or another role that I haven't captured in this list? So just use the poll answer like we did at the beginning of the session, and pick A, B, C, or D.
Okay.
Okay, so we have mixed a number of researchers, and then some of you said none of these, so presumably that would be other. Okay, so we have a bit of a mixed group on the line, and so it's good to know, and a few policymakers as well, so that's also good to know. So a definition of evidence-informed policymaking, we've been working on this definition for a little while now, and we've arrived at this overview of it, and we take it to mean using the best available data and research evidence systematically and transparently. in the time available in each of agenda settings. So this means trying to figure out essentially whether a particular problem needs to be addressed or not, policy and program development, so identifying those best solutions and the benefits, harms, and costs behind that, and implementation, so things like identifying barriers and facilitators to implementing a particular solution, and then crafting strategies to address it. And by best available research evidence here, we mean the highest quality, most locally applicable, synthesized research evidence. And we often tell the policymakers that we're working with and other knowledge users that this means first looking for a perfect match to support what we'd call an instrumental or a direct use of that research evidence, and then if that's not available, then looking more broadly to support a conceptual use. So with that in mind, in terms of the definition, increasingly efforts to support the use of research evidence try to address the two factors that emerged with some consistency in a systematic review related to the factors that increase the prospects for research use in management and policy. So before I go on, just give me a second. Maybe I'll try and adjust something for my headset. I'm sorry for we tested this before, so I'm not sure why this is happening now for the sound, so I apologize. So can folks hear me a little bit better now?
You may want to just try talking just a little bit more and see if it makes a difference.
Okay, so can everyone hear me a little bit more now? When we're on the slide about options available to support the use of research evidence. Great.
Yeah, sounds better.
Thanks. I'm sorry about that, everyone. So in terms of options to support the use of research evidence, so there was a systematic review done that looked at all the different studies assessing what increased the prospects for research use in management and policy. And what came out of those, I think, almost 140 studies that were looked at, there are two factors with consistency. And the first is, and this wouldn't be a surprise to many of you on the line, I'm sure, that interactions between researchers and decision makers are critically important. So and decision makers need to be engaged in things like priority setting, research, including doing systematic reviews and deliberative dialogue. So it's that type of integrated approach to knowledge translation that CIHR so often talks about. And the other piece was ensuring the timing and timeliness of research evidence. And this means making sure that people who need the research evidence, so knowledge users, whether it's a policymaker or somebody else making decisions, health system decisions or otherwise, have the information they need at their fingertips in a way that's optimally packaged and ensuring that they're getting the highest quality and highest and most relevant systematic reviews and briefs available to them. So this involves doing things like one-stop shops where you can go to one place and know that that's going to be the best place to be able to get the highest quality and most relevant research evidence. And so with these two options in mind, we've crafted the series of webinars with Cochrane around these programs that I've listed here, and or approaches that we've listed here. So we had one on October 23rd with Kaylin Moat about one-stop shops, where he profiled health systems evidence, which is a comprehensive inventory of all the systematic reviews in the world assessing health system questions. So anything about health system governance, financial, and delivery arrangements. Today we're talking about Rapid Response Unit, which is another way of ensuring timely access to research evidence. And then on January 21st in the new year, John Levis is going to be talking about evidence briefs and stakeholder dialogues based on our model here at the forum about how do we package research evidence in a different way in evidence briefs, and then convene many health system leaders to come and deliberate and have off-the-record deliberations about problem options to address the problem and implementation strategies. And more recently, we've now been engaged in citizen briefs and panels, which is geared towards getting research evidence out there to a slightly different target audience, citizens, but then also facilitating interactions between researchers and citizens, and having these panels to get at the underlying values behind what they think of certain health system issues and solutions towards them, and then feeding that information back up to policymakers so they can make decisions informed on on what citizens' preferences and values are. So Francois Pierre-Gauvin is going to be giving that webinar on the 23rd of February. And then the last webinar is focused on capacity building. So again, this is on the timeliness as well as interactions piece. And Kaylin Mope's going to be coming back to give another webinar on March 18th about that, and most principally about this new educational program that we have called Health Systems Learning. And he'll talk more about it then, but we do have upcoming cohorts that people are able to sign up for Health Systems Learning related to finding and using research evidence. And so that workshop is based on a workshop that John Lavis has delivered in many different countries around the world with policymakers about how to find and use research evidence to clarify a problem, to identify solutions, and craft implementation strategies. So we have one coming up in February, and then I believe another one later on in the spring for people who want to sign up for it. They can. It's on our website at the McMaster at www.mcmasterhealthforum.org, and then you can go under the Policymakers tab and find the link to Health Systems Learning. So to jump into the piece about rapid responses, the first bit of rationale are that the reality is that many health system decision makers need to address pressing health system issues in very short periods of time. Sometimes they have longer to work up a policy analysis, but oftentimes there's a need to turn around information within days or weeks. And so we need to be able to get research evidence in their hands when they need it, given that that's the timeline that we're working with. And as I said in the definition around evidence-informed policymaking, this research evidence can be really quite fundamental to help them define or determine how best to define a problem and ultimately determine whether it's something that they need to be paying attention to at any given time. Also to identify those solutions to address the problem and implementation strategies. And the second rationale is that we see that there is and has been a gap that exists in efforts to support the use of research evidence for health system decision makers in Canada. So decision makers could turn to what we'd call self-serve approaches, things like one-stop shops, health systems evidence that I spoke to just a little bit earlier, where you can go and find optimally packaged systematic reviews through searches on the database. Or you could engage in full-serve approaches like stakeholder dialogues informed by evidence briefs. But the reality is that given that many often need support with finding and synthesizing the available research evidence, so for instance using things like health systems evidence and then also pulling things together and synthesizing it, but they also need to do that within timelines that are too short to engage in the full serve approach that would otherwise do that for them as well. So there's a gap between those two things, and that's where we see the rapid response program as lying between. So to fill that gap, decision makers might turn to their own internal evidence support services, so these might, unfortunately, sometimes may lack some transparency in the systematic approach that might be used in more formalized programs. And similarly, turning to researchers with whom they have an established relationship with, it might be a quick one-off sending of a paper or something, but not a systematic approach to identifying the best available research evidence in the form of systematic reviews and quality appraising and synthesizing across a body of research evidence. Or if you're lucky enough that your question relates to or could be addressed through one of few formalized rapid response programs in Canada, then that's where decision makers may turn to as well. So there are a number of other groups in Canada who also do this type of work. CADIF, for one, has been doing it for a number of years, and they're focused specifically on, CADIF being the Canadian Agency for Drugs and Technologies in Health. They're focused on questions about technologies and drugs. So also in Quebec, they're focused on questions about drugs, health technologies, and health and social programs for Quebec decision makers. A program that I developed and led for 5 years at the Ontario HIV Treatment Network does this for HIV programs and services. And then there's also one that's been developed through a partnership between the University of Ottawa and the Ottawa Hospital Research Institute, and that's specifically to address questions from the Champlain Local Health Integration Network. So what this means is that decision makers who have questions about problems, options, or implementation considerations related to health system challenges, so specifically around health systems and things like governance, financing, and delivery arrangements, are often left with no formalized supports to be able to fill this gap between self-serve and full-serve approaches. And to try and develop work around this area, we got a small grant from the Partnerships for Health Systems Improvement Fund to convene a half-day stakeholder dialogue, which we did in March 2014. And we brought together 11 participants from across Canada, and all of those participants agreed that there was a very clear need for this type of program that's specifically directed towards addressing health system questions in a very timely manner for knowledge users or decision makers. And so the key recommendations that came out of those deliberations were to undertake a process to build a governance model, decide what can be done in what timelines, and then to also really pay a lot of attention to evaluation, meaning that we need to first define success and then also be able to reliably measure it. And so I have a few slides about that specifically at the end of towards the end of this presentation. And if you're interested in learning more about the dialogue, we wrote both an issue brief as well as a thematic summary of the dialogue that's available on the McMaster Health Forum's website. If you click on the products page on our homepage, then you'll be able to find it through that. So in terms of eligibility for a request, we managed to get this program off the ground through funding that we received through a Health Systems Research Fund grant from the Government of Ontario. And that allowed us to develop all the processes and mechanisms to actually be able to provide the program. And that funding at the moment allows us to provide those funding to complete 4 requests per year for Ontario-based knowledge users. So the idea is that once we have the opportunity to hopefully renew that grant that we're hoping to scale up, how much we're able to deliver in Ontario. And it also means now that we have the program up and running so we can offer it to knowledge users outside of Ontario, but we have to be able to do that at the moment on a cost recovery basis. But it certainly means that we're more than open to be able to taking requests from around Canada for questions about problems, options, and implementation considerations related to health system challenges. And so we're actively trying to scale up this program. We've just submitted with a number of different partners from around the country a Partnerships for Health System Improvement grant to be able to allow us to develop, to have funding to do more requests across the country and to evaluate the program. But as I said, we're still more than open to be able to do these for others around the country just on a cost recovery basis at the moment, and hopefully you have funding to do that more systematically in the future. So examples of ones that we've done so far through our Ontario-based funding that we've had, first one, or the most recent one, is about effective suicide prevention interventions. And this one recently had some very discreet uptake. Some of you may have seen the Globe and Mail article recently about the recommendations around suicide prevention interventions that Toronto might want to take up, or has been recommended for Toronto to take up and others to take up. And that report that those recommendations were based on were extensively cited the rapid synthesis that we put together at the forum, and they pulled out many of the recommendations directly from that rapid synthesis and included them in the Toronto Public Health Report. We also did one in the spring about priority setting about primary and integrated healthcare interventions, which informed some preliminary work by the SCORE network on primary care about a priority setting process that they're hoping to engage in. We did one for the Ministry of Health and Long-Term Care about rehabilitation care models for seniors, looking at the effectiveness and cost-effectiveness of those models. And we also did one, the first one we did was about optimal treatment approaches for people with multi-morbidity, so those living with 2 or 3 or more chronic health conditions. And at the moment, we're currently working through a request about patient information for emergency response, so a very timely topic, as well as one that we just received a few days ago about factors affecting safe or effective practice. So interested in identifying what allows essentially a medical practice to grow, to do well over time. So I'll stop there and revisit a poll again. So based on your experience with the Canadian context, You may have heard of the terms rapid reviews and rapid syntheses, and do you take these, based on your experience, to mean the same thing? So if you could answer yes or no using the response options again at the top. Okay, so it seems like most of you are saying yes. There's a number of you who didn't respond, but there was one person who said no. So I've got a slide about comparing, and I actually do see them as distinct products, and the next slide covers this. And I do think that the terminology is important, and sometimes these terms are being used synonymously, but I see them as being fairly distinct. So I've pulled out 3 different characteristics in terms of timeline questions, the types of questions addressed, as well as the types of evidence used in a rapid synthesis versus a rapid review. So for the first one, timeline, and for a rapid synthesis, we see a rapid synthesis as being in days or weeks, whereas what's been written up in terms of rapid reviews, people see those as being a systematic review, but just conducted in a very compressed timeline, so several months versus a year or more, whereas a synthesis is really that very, very short turnaround time. And in terms of the questions addressed, I see rapid syntheses as often addressing many different types of questions based on the policy priorities that's driving that request coming to the rapid response program. And often those policy questions about health systems, for instance, often contain many different components. Whereas in a rapid review, because it is typically a systematic review done in a compressed period of time over months, it's usually assessing the effects of a single option or an intervention. So a much more precise question for the most part. And then the last piece about the types of evidence used, because of the nature of rapid syntheses having to be done over days and weeks and addressing many types of questions, are driven mostly by drawing on systematic reviews, because being able to draw on people's work who have already synthesized the best available evidence about a given topic makes it much more efficient to be able to pull that into a rapid synthesis and present findings from reviews rather than having to wait through individual studies, do quality appraisals, and make sense of a whole body of literature based on single studies, which is more where the rapid review paradigm sits, in that it is that full systematic review being done in a compressed period of time and looking at single studies and doing the synthesis across those studies. And sorry, I saw the question pop up about whether slides will be available, so I believe these will be available afterwards and then posted with a recording eventually. And so now coming back to that, can I just ask whether you agree with these distinguishing features of rapid syntheses versus rapid reviews? So I'm mostly interested because this is something we're increasingly just trying to engage with in terms of trying to distinguish what we mean by these different types of products. Okay, so it seems as though roughly the same as the last responses, that most of you agree with these distinguishing features that I've now presented, with only one of you not agreeing. So I'm open to different interpretations of this. So if the person who didn't agree or others who are unsure about this have questions about it at the end, I'm happy to take questions about the specific topic once we've rolled through the slides. So in terms of the actual rapid response program, the overall goal, as I mentioned, is to provide optimally packaged, context-relevant, and high-quality research evidence for knowledge users over short periods of time. So with what we can deliver being very dependent on the type of timeline provided. So this very basic schematic I provide you just really emphasizes the fact that a requester gives us a question, we work with them, within the first day or two to refine that question into something that's researchable. We develop and conduct searches. We quickly review those search results, take what's relevant, and then quickly synthesize that oftentimes in a brief or more detailed summary, and then feed that back to the requester within the timeline that was defined for us. In terms of submitting requests, so if any of you want to submit requests or know others who do, requests can just be sent to our McMaster Health Forum email address at mhf@mcmaster.ca. And often we ask that each request should provide a number of different things. So first, obviously, the question that you'd like to have addressed, and then also the timeline around that request. We offer timelines on the 3, 10, or 30 business day scale. And also, it's helpful to have a brief rationale for or context for the request so that we can use that to inform the background for the document that we end up writing up. So ultimately knowing what the purpose is behind the request being submitted. And also any other background information already collected about the question. This is actually quite helpful for me and others who are developing search strategies, because if you have a paper that you already know about that's very, very relevant to what you're looking at and just want more information, it's helpful to be able to draft a search strategy, having those 1 or 2 papers handy. And then other organizations or program areas that may benefit from the rapid synthesis to help with any dissemination efforts that we might do. In terms of what we can do for each of these products, I'm just going to run you through what we can do and can't do for each of the 3 different products. So for the first one, for 3 business days, what we can do is identify systematic reviews and economic evaluations relevant to health systems through key databases. So because we sit on the health systems evidence database here at the McMaster Health Forum, we're able to rapidly use that to efficiently mobilize the available systematic reviews relevant to health system questions and pull them together in summary tables for the 3 business day response, where we highlight things like key findings from those reviews, quality appraisals of those reviews, because every review in health systems evidence has already been quality appraised. We can copy that directly into the table, and also identifying the countries in which studies included in those reviews were conducted, which is also information that's already available in health systems evidence. So because of the three business days is obviously a very quick turnaround, we feel that this is what is most feasible to be able to be done within that time. So what we can do is identify primary research studies, so things like published studies and unpublished reports, conduct quality appraisals for any reviews that we find that aren't already in health systems evidence, given that that's more of a laborious process, prepare a detailed summary of the findings, engage experts to do what we'd call a merit review, conduct jurisdictional scans of what's being done nationally and internationally to complement the research evidence, and obviously to conduct a full systematic review. So for the second product to be done within 10 business days, what we can do for this is, similarly to the other one, identify systematic reviews and evaluations relevant to health systems, but also identify relevant primary research studies, but when limited evidence is available from systematic reviews. So we first focus on systematic reviews, and then if we come up empty, then we kind of broaden our scope and look to primary studies that might be particularly helpful to informing the question. We provide summary tables similar to what we do for the 3 business day requests, but we would also prepare a brief summary of the findings from systematic reviews and where relevant primary studies to complement those summary tables. And then we also engage experts to conduct a merit review, and so that the draft summary is sent back to the requester before the merit review is done. And then the final summary and revisions from the merit reviewers' feedback is sent again within another 5 business days. So the merit review helps us have another set of eyes look at the synthesis to make sure we haven't missed anything critical or haven't misrepresented any of the information from the evidence, and kind of a quick peer review process. So what we can do here is do things like systematic searches for gray literature that could be very helpful. It's not already contained within our health systems evidence database, which does contain a number of policy documents through our evidence-informed healthcare renewal portal, for example. We can't prepare a very, very detailed summary of findings, given that it's only a 10-day business day turnaround. We can't incorporate the feedback from merit reviewers within the 10-day timeline, but we can within 15 days. And we can't conduct jurisdictional scans or a full systematic review. And then for the last product, 30 business days, what we do here is same as the other one, searches for reviews, economic evaluations, and primary studies. We can also do rapid jurisdictional scans if needed for what's being done nationally and internationally through targeted searches. Similar to before, consulting with experts with knowledge of the topic to identify relevant research evidence, providing summary tables, same as the other products, and this time also preparing a much more detailed summary and engaging in merit review within the 30 business day timeline. And then really the only thing we can't claim to be able to do within the 30 business day timeline is that it's a full systematic review. Doing searches and synthesizing within that time means that there's the risk that we haven't been absolutely comprehensive and need to find everything, so we can't claim that these are a full systematic review. Which is why I pulled a distinction between what I see as a rapid synthesis being done within these compressed timelines versus a rapid review, which I do see as systematic reviews just done just done much more quickly than a traditional review that might be done in a year or more. So my last poll for you, do you think that the first product, the 3-day rapid synthesis, is something that knowledge users would request over a 10 or 30-day time period? So I'll give you my rationale for the question in a little bit, but it'd be great to hear your answers about what you think about the utility of that product versus the other two. Okay, so a number of you said yes, 2 of you said no. So it's interesting that during the stakeholder dialogue that we held in March with a few policymakers from across the country about this, a number of those policymakers spoke out fairly strongly saying that the 3-day rapid, they'd be surprised if the 3-day rapid synthesis product was used, because the view was that that type of function is covered off relatively well through internal processes within ministries of health around the country, and that because of the rapid turnaround, they'll just end up doing it internally with their own resources, whereas if they had a little bit more time, like 10 or 30 days, and they'd be turning to a program like ours to be able to put together a synthesis. And so we're still offering about it. I was just interested to hear the response from folks on the line about whether you thought that that would be something that would be used. My sense is it could have some utility as well, but we haven't yet had one of those requests. So for the last bit about the program, just a little bit about identifying success and measuring it, because I see this as being a really important part of what I call policy-focused knowledge translation interventions in general, that we need to know whether and how things are working to keep improving and refining them as we go along. So we came up with some short and medium-term areas of success that we highlighted as part of that stakeholder dialogue and got some feedback on it, and this is where we arrived at. So we looked at one, assessing the usefulness of the program organization in general. So asking questions from requesters about things like whether the program is organized in a way that helps them to efficiently make a request and receive a timely response. So some more pragmatic questions, as well as usefulness of the final product itself. Was the synthesis presented in a way that was easy to understand? Did it use relatively simple language, easily engaged? Did it have the information that they needed? And those types of things. And then we also want to measure the influence on behavioral intention to use research evidence. And the rationale for that is that the causal chain between having some sort of evidence support service like the Rapid Response Program and actual research use and improving health systems is very, very long. And so we had published a protocol for a randomized controlled trial a number of years ago where we arrived on assessing behavioral intention as the closest, as the best option for an outcome measure in terms of that long causal chain effect. The idea being if we can have an effect on behavioral intention, that presumably we can eventually have an effect on actual behavior down the line. And then the last more medium-term area of success is assessing whether and how rapid syntheses inform policy and supported action. And so the plan for doing this, and we're currently putting this together, and it's part of our application that we recently put in, is to conduct a brief survey at the time of sending the rapid synthesis back to the requester about areas of success 1, 2, and 3. So about the usefulness of the organization, the final product, and their self-assessment of behavioral intention. So that behavioral intention is based on a validated survey from the theory of planned behavior. And then following that, we do a T2 evaluation that consists of a brief semi-structured interview. So very targeted, 20, 30 minutes at the most, connecting with the requester of the rapid synthesis, running through those questions first about the behavioral intention to get a second measure to see if it changes over time, and then doing a more set of in-depth questions asking about how this rapid synthesis was used, so more of a qualitative approach to finding out what happened afterwards and do we have any discernible impact. So what next? As I mentioned a couple times, we're trying to build a pan-Canadian rapid response program. So we're very eager to work with partners around the country. So we've started this process. We are currently collaborating with the Ontario and Maritime Force Support Units and knowledge users from BC, as well as from Quebec. And we're actively seeking to try and build partnerships in each and every province and territory across the country. So if any of you are interested, then feel free to contact me following this. We've put in this through the application, but we're keen to continue building this governance model and our partnerships as part of that. And then as part of that application we put in, we're hoping that we're successful, and if we are, we'll be able to do things like develop, provide, and evaluate a training module for others that are interested in producing rapid syntheses. Identifying and existing all the rapid syntheses around the world that have addressed health system questions and packaging and making them available and searchable through health systems evidence. And then continuing to conduct rapid syntheses and being able to do that across the country, at least provide us with funding for doing more syntheses across the country in evaluating the rapid response program. And before we close off and go to questions, I just wanted to flag a few upcoming events that we are running through the McMaster Health Forum. So through the McMaster University's LaBarge Optimal Aging Initiative, we've had a series of public talks this term related to optimal aging, and the next one we have coming up, which you can join remotely if you're interested, so you can join online. And I have the link on the following slide. It's about there's no place like home, providing alternatives to hospital care. So it's Graham Ellis joining us from the UK, and specifically the University of Glasgow has done a lot of work on the hospital at home model that the UK uses a lot. So I think it would be a great talk. If you're interested in joining, please do. And these are other talks that are coming up. So on December 8th, we have Janice Keefe joining us about preparing the system and the caregiver for what lies ahead. And then we have Richard Schultz from the University Center for Social and Urban Research at the University of Pittsburgh talking about Alzheimer's caregiving. And so the link is here if you're interested. And so this is just our last slide. So again, just to reiterate, so we're happy to take requests for rapid syntheses from across the country and work out how we might be able to pay for that going forward. And now I'm just happy to take questions. So if folks have questions for me, then I think we have a bunch of time to be able to work through those.
Thank you very much, Mike, for presenting today on the Rapid Response Program. Could we all send Mike a round of applause before we get on to questions? And just a reminder for those who have registered for this webinar, we will be emailing you a PDF of today's presentation in a day or two. And if you haven't registered and would like to receive the PDF, I know some of you have joined late, request it from Ali Marshall, and she will put her email address in the chat box. See, I did want to cover also the fact that we do have evaluations, and Alicia will also be putting information in the chat box for you to link in to complete the evaluation. It's quite short, and we really do value your opinion. And as Mike had mentioned at the beginning, please join us for the other webinars in the policy series coming up in January, February, and March. And you can register for these at this email address, and Alicia will also be placing that into the chat box. And finally, a bit of a plug for Cochrane Canada. We are having a symposium, the 12th one, and it is taking place in Calgary, Alberta at the end of May, and perhaps you could join us for that. We would love to see you there. Now, we do have a couple of questions, Mike, and I can start here. Someone said they also have heard rapid synthesis called evidence briefs, and then there was a bit of a conversation going on there saying, is there a common understanding for these terms, and what about other terms used for the same or similar products? And it kind of boiled down to, well, you know, is this really so new, these products, that there are a number of different names? Are they used interchangeably? Do people really understand the terms right now?
Yeah, I think it's a great question, and so I'll start off with the first part of the question about them being called evidence briefs. So I see rapid syntheses and evidence briefs being actually very distinct products. So evidence briefs are more part of that full-serve approach that I talked about towards the beginning, that are often packaged with stakeholder dialogues, where an evidence brief unpacks all of the research evidence related to a policy problem, maybe three options to addressing the problem and implementation strategies. And so inevitably that process takes longer than days or weeks to be able to pull together. And it's somewhat different from a systematic review in that we're mobilizing many systematic reviews as part of an evidence brief to address the problem, options, and implementation. Whereas a rapid synthesis is just done in a much more compressed time frame. And I do think it's that compressed time frame that distinguishes what I see as rapid synthesis from rapid reviews. And I don't mean this to be a splitting hairs exercise, in that, but I think using terminology is really important because lots of people are getting interested in this, which I think is great. And I just think it's important to be able for the community to be clear about, what is a rapid review, what is a rapid synthesis, or whatever it ends up being called, and that rapid review is actually meaning a full systematic review just done in a compressed timeline of months, whereas rapid synthesis is putting a term around what I think you might be quite right, that something that's been perhaps done for a long time, especially within ministries of health, where you're rapidly pulling together the research evidence in the time you have, and packaging it in the best way that you can so that it makes the research evidence easy to review and pull on to inform policy. So I feel like those are the main distinguishing factors for it, at least in my view.
Okay, thank you, Mike. Now, I do believe, but maybe you can just reiterate this. Maybe I missed it. There's a question here, but can you give me some specific examples of the topics or subjects of these requests or responses?
Yeah, so that's fine. So we covered this earlier. There is a slide, so if you get the slides afterwards, there's a list of ones that we've done. And so one of the more recent ones was about identifying effective suicide prevention interventions. And the example there is that it was actually very instrumentally used in a recent Toronto Public Health report on suicide prevention strategies that received some coverage in the Globe and Mail earlier this week. And then others were about priority setting processes and integrated primary health care interventions. We've done one on rehabilitation care models for seniors, one on multimorbidity, and we're currently doing ones on identifying personal health information for in emergency situations, as well as factors that lead to unsafe medical practices. And so I think I saw a related question to this further down about whether they're available. So we always make all of our products at the McMaster Health Forum publicly available through our website. So if you go to our website at McMasterHealthForum.org, then we have a link on the left-hand side for our products, and you can find all of the products that we've written, and they're all available open access for anyone to retrieve. Because I think it's a good point that the person made that ultimately these products could be helpful for other knowledge users as well, not just the person who made the initial request, so those do sit in the public domain.
Thank you. What is the capacity of the team? This is a question that came from one of the
so it's great. It's a great question about the capacity. So we have, as I mentioned, we have some funding from the Health Systems Research Fund, and so I'm the lead for it, and then we have depending on when, we have to be nimble because it depends on when requests come in. So we have a number of students, both undergraduate and graduate students who work with us, and so at any given time when a request comes in, it'll probably come in to me. I'll work with the requester to refine the question, and then we'd start doing searches, which I would probably be the lead for developing, and then I'd work collaboratively with some of our students to start pulling out key findings from the relevant reviews or primary studies, and then also working with our smallish team at the moment to be able to pull out those key messages into a helpful synthesis.
Okay, thank you. There's a further question. You talked about collaboration across the country. Is there any partnership already established with other universities or research centers in Canada?
Yeah, so that's a great question, actually. We have done some work on this front. So the most notable one is with Mathieu Ouimet at the University of Laval, who has been doing some rapid synthesis work and is collaborating with us on this scaling up project through the Partnerships for Health System Improvement grant. We've also engaged a researcher from University of British Columbia, Michael Law, who agreed to collaborate with us on this as well. And so that's just our efforts of our preliminary partnership building. It doesn't mean that we're keen to engage others across the country as well.
Okay. A further question. Well, there's a little bit of a lead up to it. It says, first of all, thanks for the great presentation, Mike. There are many people offering such services across Canada, and it seems like some kind of standardization, collaborative approach, to serve knowledge users through the support units would be very helpful. Can you tell us who owns the final product? Assuming that the client assuming it's the client, can any research be published on it? Are there reviews public? Presumably, it'd be of interest beyond the client. So I guess if you want to attack the first one, I guess who owns the final product?
Yeah, so I think I partially tackled part of the question through my previous response, that the rapid syntheses that we produce are available publicly on our website. So we produce them through the McMaster Health Forum. The request comes in from the client, but they're posted in the public domain. We haven't had this instance yet, but where there's kind of a sensitive political issue, our initial approach to it is that we could hold off on publishing the synthesis until, for a month or so, until kind of the sensitivity around it might have waned. But we haven't encountered that situation before. But we always have a commitment to making all of our products publicly available. And for the first part of the question around some kind of standardized collaborative approach to serving knowledge users through the support units would be very helpful, and I agree. So our key knowledge users on this FISI grant for the Ontario Spore Support Unit and with the Sanity, Srinivas, and the Maritime Spore Support Unit with Adrian Levy, and we're actively trying to engage other spore support units as well as they're becoming, as they're being developed and coming up to speed. So we see those spore support units, and at least that's what I think you mean by support units, as being critical, because this is just so important to the mandate of those units across the country. And it gained a lot of interest from both DeSanti and Adrian when they spoke about it. And I do think there are other services offered across Canada. When I profiled the programs that we've found being available, we profiled the more formalized programs that we've been able to find. I think lots of these functions are done on an informal basis, especially within many ministries and other organizations. I was just profiling the formalized programs that we've been able to locate. It doesn't mean that we also haven't missed anything.
Okay, thank you. Does the summary of results in the synthesis products include a quality appraisal of the included reviews studies?
Yeah, so we do quality appraisals of all the systematic reviews that we include. So if it's a 3-day synthesis and it's a review from a database that we've found from a database other than health systems evidence, then we aren't able to provide a quality appraisal in that instance, just given the timeline is too short. But we do commit to doing quality appraisals for all the systematic reviews that we include for the other two products. And then, sorry, I just see the next question is somewhat related about telling us about the relationship with healthevidence.ca. So many questions about systems sometimes overlap with public health questions, which is what healthevidence.ca, that's run by Maureen Dobbins, addresses. And so the example is the one we did on suicide prevention interventions. Many of those interventions overlap between a systems level approach as well as obviously a public health approach. So we pulled extensively both on health systems evidence and healthevidence.ca in that instance, given that many reviews about suicide prevention interventions were indexed within healthevidence.ca.
Okay, there's a further question. My question is, how do you manage requests beyond the first 4 rapid synthesis?
Yeah, so at the moment, our demand hasn't been overly high just because the program is beginning up and running, but the overall approach is to first figure out the timeline, and then we cost out how much in terms of how much staff time it's going to be required to actually conduct that synthesis, and work out at the moment how much that we would need to charge someone to be able to do that within the time frame.
Okay, and I guess that's the next question about the price range for these products. How would you determine the cost recovery model, which I guess you have actually addressed already, but do you have any idea as far as the price range of the products?
So our managing director of the forum kind of takes care of a lot of that stuff, and she has costed some of this out. Sometimes it's dependent on the question and how comprehensive the question is. I mean, if it's something that's done, very quickly, then obviously the cost is going to be lower. So it's, I just have to say it depends. And so, if someone's interested, then I'm happy to connect with them offline and figure out what the costing might look like.
Okay, and there was another further question on it was the same question about costing. There is a question that says, just responding to your comments about open access, what if there was a government request for a confidential review? Have you ever come across that?
Yeah, so we haven't come across that yet, and it's something that came up in the dialogue that we ran, but and it's a very good question, because obviously there are a number of confidential things that governments have to deal with at any given time. And our preferred approach at the moment is that we handle this we're willing to potentially defer the publication or making it publicly available for a period of time, but ultimately still making it available in the public domain. So I think that's the approach for the moment, is that we kind of work on an individual basis to figure out how long we might need to postpone the publication of that particular review, given the sensitivity around it, but then still ultimately making it available.
Okay, thank you. Do you have a list of references addressing evidence of robustness, reliability of rapid approaches versus systematic reviews?
I don't have that readily available to me. There's been, just at my fingertips at the moment, but there's been a small number of papers written about this. There's one recently in implementation science by Rona Majumbi, who's run a rapid response service in Africa. There's been another one, I think, coming out from Julie Polisena from CADIS, talking about rapid reviews. And I think that was published in the International Journal for Technology Assessment in Healthcare, but I could be wrong. But I think we'd probably cite them in the issue brief that we published. It's on our website. So I'm happy to try and look into it if someone wants to email me afterwards, and I can connect them with the resources that they need. So there isn't a whole lot published in this area yet. There are a handful of papers.
Okay, and everyone can see the Mike's contact information on the screen if you'd like to email him about that. So another question, I'm wondering if it would be the McMaster Health Forum leading the work to standardize this work across the country, or would it be the SPORE units? Any insight into that at all?
Yeah, so we're working with the SPORE units as our partners, but we see the McMaster Health Forum as how we framed it as being the central hub for these activities, that because we're sitting on the health systems evidence database, and because we've managed to build up the program already, we see ourselves really in that coordinating role and being the centralized point for it. But that still means working very extensively with our partners to do this type of work. So yeah, I see us as being the central point, and then collaborating with partners to potentially conduct some reviews in some instances, but with us working closely with them as well. And then I see Bev's question about who owns the final product. So I mean, ultimately, it's a McMaster Health Forum product. It goes in and it goes out as being published by the McMaster Health Forum, but again, it's open access, so anybody's able to actually use it. So if you want to pull information from it, it's just like citing any other document that you would.
So that was in reference to the who owns the final product?
Yeah, Bev.
Yeah, from Bev. Yeah. I don't know. I know Bev is. She's actually writing something right now.
Okay.
The ownership question, she says, is tricky when people are paying.
Right, so it's a good point. And so we haven't worked out all the issues with this yet, but I mean, people pay research organizations to produce many types of research products as well, and so I think that model has often been used to publish findings through that funding model too. So I guess that is kind of the approach we're taking now.
Okay, so I guess you'll have to see how it unfolds. Let's see. Good point. She says. Okay. Well, there don't appear to be any other questions. There's quite a flurry of questions, which was absolutely excellent, and thank you very much for answering them. I'd like to take the opportunity to thank you very much, Mike, for presenting today. We appreciate it, and please let's give Mike a round of applause.
Thanks for coming, everyone. It was great to be able to engage with all of you. And as I said, if you have any questions, then feel free to email me.
And we hope to see you at the webinars that are coming up in the new year.